Okay, week 2, I want you to be able to think about what you would do at your prenatal visits with your patient that you'll be taking care of. Your first prenatal visit being different than your routine follow-up prenatal visits. So your routine lab testing that you should expect to perform on your patient at the first visit, blood typing and an RH factor. So your blood type is A, B, O, or the combination of AB. And then your RH factor is whether your patient is positive or negative. And indirect Coombs, and all the indirect Coombs test tells us is if it's an antibody test to tell us if there's antibodies present in the blood that will attack the mom's red blood cells. Hemoglobin hematocrit, which would be just a routine CBC. A rubella titer, so we want to know if mom is rubella immune. If she is not, then rubella can actually be harmful to the fetus. If she is not rubella immune, then we will actually not vaccinate her during pregnancy because it's harmful to the fetus. It's a live vaccine. So we will not give that until after the baby is born, and then educate mom not to get pregnant for at least 28 days. We'll do an HIV test, an RPR, which is a test for syphilis. Again, because we want to know if mom is positive for syphilis, because syphilis can be harmful to the baby. The good thing is, if mom is positive for syphilis, is we can treat her for that and hopefully prevent the problems of the syphilis just with antibiotics. A test for syphilis also that you may hear is VDRL instead of RPR, a test for the same thing. We're also going to test for hepatitis B. If mom happens to be hepatitis B positive, we will treat baby a little bit differently at birth. So not only will it get its first hepatitis B vaccine within 12 hours, but it will also get a hepatitis B immunoglobulin after birth. So that's how it differs a little bit differently than your normal newborn infant. So everything we've mentioned so far comes from a blood test. So mom will get her blood drawn. And then in addition to that, at her first prenatal visit, we will also perform a pap smear, a pelvic exam. Additional lab testing, and this is moving on. We're outside of the first prenatal visit now, so we're at the follow-up visits. At 15 weeks, we mentioned at the last class the maternal serum alpha-fetoprotein for genetic screening, offered around about 15 weeks gestation. At around 28 weeks gestation, we do glucose screening for gestational diabetes. First, they'll do a 1-hour glucose test where they do a 50-gram load of glucose, and an hour later they check mom's blood sugar. If it's less than 140, she's good to go. If it's above 140, they will order a 3-hour glucose test where mom will fast, she won't have any caffeine, she won't smoke for at least 12 hours. They'll take a fasting blood sugar. They'll give her a 100-gram load of glucose and then take a blood sugar at 1, 2, and 3 hours. If she's abnormal on these ranges, then she will be considered gestational diabetic. The bad thing about gestational diabetes, and there's a nice little picture in your PowerPoint slide of the complications of gestational diabetes, but the babies can be very, very large. What do you think about adult diabetic patients pee a lot? Well, diabetic babies or babies of diabetic moms can also pee a lot, so they can get a lot of amniotic fluid, which is polyhydramnios. The babies can be large, can cause shoulder dystocia, which is the baby not being able to come out. Babies produce extra insulin in utero with gestational diabetic moms because they're used to all that sugar, so their bodies automatically create more insulin in order to compensate for that. So when they're born, their bodies still are producing extra insulin, but yet they don't have the extra sugar from mom because they're outside of utero. So babies will tend to get hypoglycemic after birth if mom was gestational diabetic. At 37 weeks, we do a routine vaginal/rectal swab for group beta strep. Group beta strep can be harmful to the baby. It can even be deadly. It can be harmful to mom in a sense that it can cause preterm labor and whatnot. I have actually a wonderful presentation on group beta strep that I will leave for the class time, but that's done around 37 weeks gestation. Signs of complications we want to cover with our patients at each prenatal visit, and you know, we can kind of tailor a little bit more specific complications depending upon how far along they are in pregnancy. Always mention vaginal bleeding, persistent vomiting, chills and fever, sudden clear fluid from the vagina, abdominal or chest pain, pregnancy-induced hypertension. And of course, we don't want to just say this. We'll mention the signs and symptoms of those, you know, after 20 weeks gestation, obviously, and we'll talk about that a little bit later on. And increased or decreased fetal movement. This would only be appropriate after they start feeling the baby move, which is around 16 to 20 weeks gestation. Teratogens. So the definition is a drug or other substance capable of interfering with development of the fetus, causing birth defects. So the acronym TORCH stands for toxoplasmosis, other, rubella, cytomegalovirus, and herpes. So all of these are things that can be harmful to the fetus. Toxoplasmosis can be contracted from infected cats. So if you're cleaning a litter box of a cat that was infected with toxoplasmosis, so any of you ladies that have been to the doctor's office and they've asked if you've had indoor kitties, this is why. Undercooked meat, animals exposed to that are undercooked, you can also contract that. And the reason they want to know is because it can be harmful to the fetus. Rubella, we've already talked about. Cytomegalovirus, they don't routinely test for this in pregnancy because it's very rare. However, if you start exhibiting signs that they may suspect cytomegalovirus, then they may test for it. Herpes, if you have a history of herpes, they may put you on preventative treatment around 36 weeks gestation to prevent an outbreak, or if you have an active outbreak during pregnancy. If you have an active outbreak of herpes, a vaginal delivery will not be an option. Live vaccines are not given during pregnancy because they are harmful to the fetus and contraindicated. So a general rule of thumb for pregnancy, an inactivated flu vaccine, influenza, that's recommended, and also the whooping cough vaccine, or the Tdap vaccine, is recommended. Of course, drugs, and when we say drugs, most people think of your illegal drugs, so I wanted to add that that also includes prescription, you know, some prescriptions that may not be thought of as bad. Of course, your pain medicine, your narcotics, and a lot of your over-the-counter medications also could be harmful to the fetus. And I'll click on your next slide here that could be helpful in helping the patient determine on whether she wants to take a medication or not. And as a nurse, I may not say, yes, you can take that medicine, or no, do not take that medicine. I may just refer them to this FDA chart. As I'll point out specifically, and this is in your book also and in your PowerPoint. In category C, says animal studies indicate risk to the fetus. Control studies to pregnant women are not available. And you'll notice Colace is a category C. That's a stool softener that some pregnant women take. So, you know, they weigh their options and decide to take it based upon what they feel comfortable with. So your pregnant women that are HIV positive or have AIDS, this is transmitted from the mother to the baby through placenta or through breast milk, so breastfeeding is contraindicated. Procedures that increase blood exposure should be avoided. So if mom is HIV positive and or has AIDS, these should be avoided. Episiotomy at birth, so that's when they cut the opening of the vagina to ease delivery. Amniocentesis, which we've already discussed. Internal fetal or contraction monitoring, which I'll show you a picture of since we really haven't discussed that yet. And vacuum deliveries I'll show you a picture of also, since we haven't discussed that yet, because these can increase blood and the exposure of the fetus to mom's blood. Also, avoid injections to the newborn until after the first newborn bath. The medication Retrovir, which used to be referred to as the AZT, is given at 14 weeks gestation and throughout pregnancy and right before labor. Retrovir is also given to the neonate following delivery and for 6 weeks. Oh, this one does not have the picture. I'm sorry. Remind me and I will show you the picture of the vacuum delivery and internal monitoring in class. I must have not saved it to the PowerPoint. Foods to avoid in pregnancy. Limit caffeine to 300 milligrams per day or 3 cups. This is what your book says. Actually, March Dime's website says 200 milligrams per day. So some people say avoid it altogether. There are no real definitions of what amount is okay in pregnancy. So just like with alcohol, avoiding it altogether is actually probably preferable. If you can't avoid it altogether, limiting it to at least amount possible is preferable. Artificial sweeteners, most are FDA approved in pregnancy. Some are limited in amounts. The only one that's not FDA approved, to my knowledge, is probably because it's fairly new, is this stevia, which is a fairly new one. Mercury in fish should be avoided. Mercury is found in a lot of your shark and your swordfish. Women are a lot of times told to eat about 12 ounces per week of seafood, or limit their seafood intake to about 12 ounces per week. Too much mercury can affect the brain and the nervous system of the fetus. Alcohol should be avoided in pregnancy altogether. Again, it has been shown that a small amount of alcohol in pregnancy is okay, but medically we are cautioned against saying that, because the right amount that is okay is debated. So we are to tell moms that alcohol should be avoided altogether. Nutrition. Weight gain, recommended 25 to 35 pounds in pregnancy, and this is strictly for your healthy, normal BMI pregnancy females, pre-pregnancy females. During the first trimester, about 1.5 pounds per month. Last 2 trimesters, about 1 pound per week. Caloric intake increased about 340 per day in the second trimester and 450 per day in the third trimester. Not very much. You're not eating for 2 people. Increase protein intake. Take iron with vitamin C and a stool softener. Avoid milk or caffeine with iron intake because it affects the absorption. Drink plenty of water. Take folic acid at 600 micrograms per day. And this pica or pica is from a nutrient deficiency, underlying nutrient deficiency, and it's when they crave abnormal things such as laundry detergent or chalk. So if that happens, they need to be tested for an underlying nutrient deficiency. Complications. All right, so we're going to start with bleeding. If a lady comes in bleeding and she says she's pregnant, we need to know how far along she is, because that is going to make the difference on what we suspect may be going on. First trimester, second trimester, or third trimester. First trimester, it may be miscarriage, tubal pregnancy. Miscarriage, we're concerned about possible hemorrhage, be a lot of bleeding, infection, sepsis, isoimmunization. So is mom Rh negative? If she is, we still need to give her a RhoGAM shot to prevent problems with future pregnancies. And then anxiety or powerlessness. Ectopic pregnancies. This is when the implantation occurs outside the uterine cavity. Most of the time it is in the tube, the fallopian tube. Moms will feel a unilateral stabbing pain and tenderness in the lower abdomen. Referred shoulder pain if the tube ruptures. And if the tube ruptures, it's an emergency surgery. If it's found early, the mom can take methotrexate to dissolve the pregnancy and no surgery is needed. If it's found later, mom will undergo surgery laparoscopically. If it ruptures, it's an emergency surgery and it needs to be taken care of very quickly before mom starts exhibiting signs of shock. Abdominal pregnancy, this is when the pregnancy takes place outside of the tube or the uterine cavity in the abdominal space. The fetus does not have any way of receiving any type of blood supply, so it cannot survive. And a lot of time, and it does not have any way of evacuating itself. So I shared a post on your Facebook page of a thing that was in the news back in 2013 about the 40-year-old stone fetus that was found in the elderly lady. And we'll talk about that a little bit in class. Pull it up. It's very interesting that it had been in there for 40 years and nobody knew about it. All right, moving on to second trimester bleeding. A gestational thromboblastic disease, or molar pregnancy, you'll hear it referred to, is an abnormal proliferation, degeneration of thromboblastic villi in the placenta that becomes swollen and fluid-filled. There's two kinds, complete or partial. The complete has no fetal parts, and the partial actually does contain some fetal parts and amniotic fluid. There's an increased risk of cancer that's rapidly metastasized with molar pregnancies. Signs and symptoms of this are abnormally large abdomens, prune-colored discharge, and abnormally high HCG levels. These moms, these pregnancies these are not term pregnancies. And these moms will have to be monitored for HCG levels for at least 1 year. If their HCG levels do not continue to decrease, so if they increase or plateau, then they need to be evaluated for cancer. So you want to educate them not to become pregnant because this will affect, obviously, their HCG levels. So another cause of second trimester bleeding is premature cervical dilation. This is when your cervix cannot hold the fetus until term for whatever reason. And cervical cerclage is what we do about this. And this is a surgical procedure. We basically just tie your cervix shut. And I'm going to explain that. I'm going to turn the lights on. As simple as possible. So, say your cervix is open, okay, and say it's too early for your cervix to be open. So in order to prevent early delivery, say you're 20 weeks, we're going to go in surgically, lithotomy position, say we're going to put you to sleep, and we're going to stitch that closed. Pretend these are stitches. Okay? So, for the next, my stitches aren't staying in place. Okay? So we're going to tie, basically, your cervix shut for the next 20 weeks, or, 17, 18 weeks. When we're ready for that delivery to occur, when the fetus is close to term, then we will go surgically in and cut that suture. And when we cut it, most of the time the moms deliver very quickly because their cervix is unable to hold the fetus, so it dilates very quickly. Okay? And here's a picture of, probably a better picture of a suture than my rubber band. And here's a picture of a molar pregnancy. Grape, it kind of looks like a clustered grape structure. Oh, I guess I need to turn up the lights so you see. There you go. Third trimester bleeding. Causes could be placenta previa. This is a low implantation of the placenta. Normally, the placenta implants high in the uterus. Okay, it can implant down towards your cervix. Risk factors: if you have scarring from previous surgeries, if you're over the age of 35, if you have twin gestations or multiples. Assessment: painless, bright red vaginal bleeding. So moms come in and they say, it could come in spurts. So they could have been at work, they could have had a gush of bright red vaginal bleeding, didn't hurt at all, and it could be completely gone when they come to the hospital. Some moms will be like, I feel foolish for being here, don't know, I shouldn't have came in, reassure them that it's okay that they're there, they should have came in. Management. First and foremost, if this happens, if moms come in and report this, do not check their cervix, okay? Any reporting of this bleeding, do not check their cervix, because you don't want to dislodge that placenta away and cause more problems. Possible betamethasone. So if possibly this mom could deliver preterm, okay? So betamethasone is a steroid that will help develop the fetal lungs. So we could possibly give betamethasone to help with that. It needs 24 hours to be effective. Okay, so we want to think ahead of time on giving that. Bed rest, nothing in the vagina, no sex, no vaginal exams, and so on. And then blood if needed. Here's pictures. So here's a complete previa, okay? And then less of a previa, and that's a partial. Still on third trimester bleeding, an abruption is the premature separation of the placenta. This occurs suddenly, and this is the most frequent cause of perinatal death. Risk factors include hypertension, trauma, cocaine, smoking, a short umbilical cord, and high parity, which means high number of pregnancies. A placenta can separate partially, not all the way, okay? Assessment: sudden, intense pain. Okay, so with your previa you had no pain. Your abruption, this is severe, intense pain, board-like abdomen. So you feel mom's abdomen and it's hard as a rock, okay? Contraction, hard as a rock, goes away. Abruption, hard as a rock, does not go away. Moms can have vaginal bleeding, but abruptions can occur without vaginal bleeding. So don't rule out an abruption even if you don't have the vaginal bleeding. And then eventually you're going to have fetal distress. If you ignore an abruption long enough, the fetal distress is going to happen. If the abruption or if the placenta is not attached to any fetal or any maternal oxygen or blood supply, that baby has no oxygen or blood supply. So it is going to go into distress. Management: get an IV on board, O2, betamethasone to develop those lungs. However, it needs 24 hours to take effective. If this is a total, complete abruption, you're going for an emergency C-section ASAP. Blood products if needed. Birth of the infant ASAP. Okay. And here's pictures of a complete abruption, partial, and whatnot. Oh, this is out of order. This is that major side effects of the diabetes in pregnancy that I was talking about earlier, about what can be caused to the fetus from gestational diabetes. That's in the wrong spot. I apologize. And here's the fasting glucose. And these are all out of order. Sorry about that. Well, we'll go on back to gestational diabetes real fast. With gestational diabetes, you want to hopefully control it with diet and exercise, okay? You may perform biophysical profiles to check on the baby's well-being and daily kick counts. If mom's going to be treated, it's going to be with insulin, not oral medications. And they're going to monitor their blood glucose daily. Pregnancy-induced hypertension. There's different definitions dependent upon the severity. I'll let you classify those based upon the definitions in your book. I'm not going to read those to you. I'm going to show you a nice video that I made for you in SimLab. I'm going to add here postpartum considerations. The only cure for preeclampsia is delivery of the baby. Okay? However, the body will not return to the pre-pregnancy state as far as blood pressure-wise until at least, usually about 24 hours. So if there's any treatment for preeclampsia during pregnancy, the treatment needs to continue for usually about 24 hours post-delivery. HELP syndrome stands for hemolysis, elevated liver enzymes, which is your ALT and your AST labs, low platelets. I'll show you a video here in just a second on your preeclampsia. Preterm labor, another complication, labor that occurs before the end of your 37th week. It's the cause of 2/3 of all infant deaths. Management, know your risk factors. Bed rest, no sex. Hydrate, treat infections. Terbutaline, also known as breathine. This can cause mom's heart rate to go elevated, so if she's taking terbutaline, make sure she checks her heart rate before taking it, because if she's already tachycardic, you're going to want to hold that medication. Magnesium sulfate, this is a muscle relaxer, okay, so it'll stop the contractions. And then here again, you see this betamethasone, develop those lungs of the baby. If we're going to deliver it early, we want those lungs to be developed. Isoimmunization. If mom's Rh negative, we're going to give her RhoGAM around 28 weeks gestation routinely. If she has any invasive procedures such as a amniocentesis, because if maternal and fetal blood cross, the problem lies in, with mom, if the fetus ends up being Rh positive, okay? So if the fetus is Rh positive and its blood crosses over into mom's blood, okay, there's no problem at the time being. However, with a future pregnancy, if the baby that she conceives in that pregnancy ends up being Rh positive, the blood that crossed over in this pregnancy, her blood will start developing antibodies against that baby's blood, and it will attack that pregnancy's Rh positive fetus and possibly miscarry it. So we will give her RhoGAM to hopefully prevent problems with future pregnancies. Now with the baby, if mom's Rh negative and the baby's Rh positive and the baby gets mom's Rh negative blood, then it can start developing antibodies against mom's Rh negative blood, and it has a higher risk of jaundice in the newborn, and we'll talk about that in the newborn lecture. Adolescents and your women over 40 are considered special needs patients. Your adolescents have developmental concerns because they're not developmentally mature yet. They have a high risk of CPD because their pelvis is smaller, which a lot of times the babies are not able to come through the birth canal. High risk for hypertension because their blood vessels are still immature. High risk for premature labor because their uterus is still immature and not fully grown. High risk for hemorrhoids, and a high risk for iron deficiency anemia because of their poor diet. Women over 40, high risk for gestational hypertension, high risk for cesarean birth, post-term birth, and preterm birth. Again, their uterus has been stagnant for over 40 years, so now all of a sudden it has to go to work and it's become lazy. Hemorrhoids, varicose veins, and also a high risk for DVTs. Drug use. We talk about the newborn and drug use with the newborn. But I also want to point out that drug use in pregnancy can cause pregnancy complications, such as preterm labor, abruption that we just talked about, anomalies of the newborn, neurobehavioral changes in the mom, obviously, and in the newborn, signs of withdrawal in the neonate and the mom. It depends on the drug being used, dosage, route of administration, and many other factors. Pull up a video for you to watch. Okay, well obviously they have me in a different room this week, so the speakers are elsewhere. So I will put the video all on the same link so you have access to them, and they're easy to access. There will be a video of me doing assessment on a preeclamptic patient that's about 9 minutes long. There will be a short 2 or 3 minute video on drug use in pregnancy. That both of those you need to watch, and there's also a video on positions for pregnancy. It's about 4 minutes long. That's helpful. We will talk about positions for labor too, so if you're short on time and you need to skip one, the position one is not as important as the other two. You need to read and look at your PowerPoint for self-care and prepared childbirth information, which is Chapter 12 and Chapter 14 in your Pilotary book. Thanks.